Great. Well, good morning and good afternoon. Always wanted to try to say that, so I did it right before the noon hour. So welcome to our third edition of Research Grand Rounds, and we're going to hear about artificial intelligence by Adam Gaweda. And to introduce Dr. Gaweda, we're actually going to have our newly minted. You can hold the applause. Actually, you can go ahead and applaud. Um, Newly minted vice chair for strategic operations and outreach, Dr. UofL, who has been our chief of nephrology. And since Dr. Gaweda is actually in her division, she's going to do his introduction. Take it away,
All right.
Dr.
Thank you very
UofL.
much, Dr. Williams. I am really happy to give this introduction for Adam Gaweda. Adam actually did his electrical engineering in Poland and then came to Louisville, Kentucky to do his Master of Clinical Sciences and his Ph.D. He has been with the division since 2003, which is impressive by itself that he's been here that long. If you look at Adam's CV, you can see that there's been a very progressive use of AI in medicine. So the very first thing that they did was actually start to model anemia in dialysis patients, which is a huge problem because all dialysis patients are anemic. And they were modeling how to use the drugs, the erythropoietic stimulating agents in dialysis patients. And using this artificial intelligence, they were able to individualize the drug therapy for the patient. So that's a huge, it was a huge cost savings, a huge improvement in patient lifestyle and their morbidity and mortality. Adam is branching out into other areas of interest in dialysis patients, and looking at patients' access, because their access in dialysis is truly their lifeline access. So without further ado, I'm going to let Adam tell you what he does.
All right. Thank you, Dr. UofL, for this nice introduction. The title of the talk today is Artificial Intelligence for Disease Management. And we're going to get over 20 plus years of our adventure at the Division of Nephrology and Hypertension using AI and machine learning methods for treatment individualization. Let's start with my disclosures. I have intellectual property equity and scientific advisory board membership with those who has licensed out intellectual property will be mentioned in this presentation. So let me start. Let me give you a good general definition of what artificial intelligence is, so we are all on the same page. You hear a lot about artificial intelligence in the news, and there's a lot of stories about these new fancy methods and tools of making it here. But let's go back to the basics and just go over a general definition. So, in my opinion, and many other scientists in this area, this artificial intelligence is a study of transferring human skills and abilities, such as learning and reasoning, abstraction and pattern recognition, planning and decision making. It's all about transferring these skills into the digital world. If you look at most of the artificial intelligence methods that are in the mainstream right now, they will really fall into one specific subcategory of this field, namely it's the machine learning. And when we talk about machine learning, we generally look at three different subdomains slash method learning that are in use. The most popular one is supervised learning. Next one is unsupervised learning, and last but not least, perhaps the most exciting one, at least for me, is reinforcement learning. Let me give you a brief overview of what these methods, methods do, just so we all have a better idea. So supervised learning It's very much like statistical linear and nonlinear regression. It uses quote unquote big data to find a mapping between information X and Y stored in the data. So for example, in the medical world, we can look at supervised learning as developing methods and tools for performing diagnosis tasks. Unsupervised learning, on the other hand, is a method of data analysis that is similar to the statistical methods for dimensionality reduction and information compression, such as principal component analysis that most everyone is familiar with. And what unsupervised learning does in general terms, it looks at the information X we had seen previously on the slide, and it tries to find patterns in that information. So let's say our information X has a large dimension. Let's think about proteomic or metabolomic data. We try to compress that information into a much smaller dimension that we can better comprehend. One very profound application area for unsupervised learning that everybody's familiar with is image processing in radiology. All of the methods, all of the AI and machine learning methods that address image processing, segmentation, diagnosis of imaging are based on unsupervised learning. Finally, the method that is of great interest to me personally is called reinforcement learning. In very technical terms, this is a way to learn sequential decision policy by an agent to achieve a desired goal. Okay. So in medical terms, reinforcement learning that actually has its roots in psychological theory of human and animal learning based on repeated interactive human and trial and error approach. In the medical world, we can look at reinforcement learning through the lens of a physician performing sequential treatment decision with a patient. So we're going to use this analogy throughout this presentation as we apply these methods in disease treatment. So for this talk, I wanted to specifically focus on two successful application areas that we have tried at the Division of Nephrology. They are all related to, obviously, they're all related to chronic kidney disease treatment. And the two specific application areas are anemia management, which we've been working on between 2002 and 2014. This project has actually resulted in a commercial product. And more recently, in 2014, we branched out to attack another challenging complication of chronic kidney disease, mineral bone disorder. And this is an ongoing project. Let's jump into the anemia management part. So what is anemia of end-stage kidney disease? It is a nearly universal complication of chronic kidney disease whose under or over treatment may have severe impact on cardiovascular morbidity and mortality. Why is anemia management treatment challenging? It is because the treatment guidelines for anemia management recommend treatment individualization. However, if you look at the response to treatment across the large patient population, this response is very heterogeneous. So individualization in presence of large heterogeneity in response to treatment is challenged by itself. Now, there are ways to standardize anemia treatment across dialysis facilities, across healthcare providers, and one of them is to create what's known as anemia management protocols. However, these treatment protocols are typically population-based. So again, they do not really, as you will see, they do not really achieve ideal control, ideal treatment of anemia. Furthermore, one very important but underappreciated aspect of anemia management protocols, they the purpose of creating an anemia management protocol is to capture physician expertise performing the treatment. Discovered that these written protocols for dose adjustments not adequately describe the experience of. Okay, so next, probably the most important thing at this time is in 2011, based on multiple clinical studies, FDA came up with a black box warning for the agents used to treat anemia in dialysis patients, so-called erythropoiesis stimulating agents.
Oh, we have the same picture.
I'm going to refer to them as DSAs. But it was discovered that excessive dosing of ESAs may result in the increase in the risk of cardiovascular complications such as stroke, MIs, thromboembolism, and so on. So FDA came up with this recommendation that in order to the optimal anemia treatment should use the lowest possible dose of ESAs to achieve hemoglobin target that minimizes the risk of red blood cell transfusions. Here's a little schematic diagram of the feedback loop controlling red blood cell and hemoglobin concentration in the human body. We see that kidney is involved in this process by producing a hormone called erythropoietin, which in combination with iron stimulates red blood cell production in the bone marrow. In patients with kidney failure, obviously, we have a diminished ability to produce sufficient amount of erythropoietin. So the current standard of treatment for this condition is using therapeutic agents, the aforementioned erythropoiesis stimulating agents. So the challenge, as mentioned before, the challenge here is to figure out how much erythropoietin or erythropoiesis stimulating agents to give to a patient to achieve optimal anemia correction. And I mentioned anemia management protocols before. Here's an example of a simple one. It's a basically set of expert rules derived by a trained physician. It's just to give you an idea of what these anemia management protocols look like. We're not going too much in depth on that part. Now, this is the challenge with managing anemia in CKD patients. Multiple observational clinical studies have discovered the fact that patients receiving anemia treatment with ESA exhibit different patterns of hemoglobin variability as a result of the treatment. The most interesting finding in this plot shown here is that for nearly 40% of the patients undergoing anemia treatment exhibit wide, excessive hemoglobin excursions between the two extremes, at which the patients are either at risk of transfusion when the hemoglobin is too low, or risk of cardiovascular effects when the hemoglobin is too high. We did a prospective study at our dialysis facilities by observing hemoglobin patterns in our patients, and we discovered that our patients exhibit the same behavior. Here's one, here's another one. Both show excessive hemoglobin variability as well as excessive dose adjustment patterns. And I want you to keep that second part in mind. So we decided to better understand this process, we decided to study hemoglobin variability first. So we were able, throughout the study, we were able to discern that there are two distinct patterns of hemoglobin variability. There is the long-term variability, which shows high amplitude of hemoglobin changes and a relatively long period, like in months. And it correlates with the dose adjustment patterns shown below. There's the short-term hemoglobin variability, small in amplitude and relatively quick, week to week, day to day. It does not, the short-term variability in hemoglobin does not show correlation with adults. We have discovered that it was related to other factors, such as patient volume status, assay error, and everything else. Why is the distinction between short-term and long-term hemoglobin variability important for us? If you're not aware, that the hemoglobin level, the change in hemoglobin level was affected by short-term variability, you may be tempted to correct that change with an unnecessary dose adjustment. So this is something that we really have to pay attention to. Okay, so we decided to tackle this problem using mathematics or mathematical modeling. We looked at the hemoglobin response over time using the simple what's called step response model. This model is essentially described by two parameters. Sensitivity, which defines how much hemoglobin is going to change over time in response to a unit ESA dose increase, and dynamics. The dynamics parameter tells us how long it will take hemoglobin to stabilize at the new steady state after the dose has been changed. We have discovered that the parameter of interest for us in our specific application was the sensitivity parameter. We'll get back to the dynamics parameter at a later stage. So we decided to study the sensitivity to ESA in our patient population. Why is it important that we study how the sensitivity to ESA changes? It's because in addition to ESA dose, there are other factors. Just like with the short-term hemoglobin variability, where we were seeing the impact of volume status, there are other factors in play that may decide how much the hemoglobin change in response to ESA dose change. And these factors are iron status, infection or inflammation, nutritional status, and dialysis addictness. So knowing how much these factors affect sensitivity of hemoglobin change to ESA, we know not to change the ESA dose when we are aware that patient iron status is incorrect, that they're low on iron. To analyze sensitivity to ESA, we used our patient data stored in electronic health records. We applied artificial neural network approach to derive this model. Having the dose response model shown on the previous slide, we decided to take our chances and start using this approach in live patients to actually guide physicians' dosing decisions. A nice term for that is in AI field is called treatment planning. So to accomplish that goal, we borrowed from the control theory. We used a method called model predictive control. And what model predictive control is, it's a combination of a dose response model and a dose optimizer that work in tandem to calculate the optimal ESA dose to achieve hemoglobin level predicted by the dose response model that closely matches the hemoglobin target specified by the physician. Once the optimal ESA dose, the ESA star, is found, it is presented to the physician for approval and prescribed to the patient, upon which the next hemoglobin level is drawn from the patient and the process is repeated at the next dosing step. This is a little graphical representation of how the model predictive control approach works over time. So at the dosing time, we have information about past hemoglobin trajectory. We have information about the past ESA dose adjustment, and we have the hemoglobin target specified by the physician. So we use that information and the dose response model to manipulate the ESA doses and look how they change hemoglobin level, the predicted hemoglobin level over time. Why is it important that we look over extended period of time at these hemoglobin changes? So typically, the dose adjustments in a dialysis clinic are performed on a monthly basis. Remember when on one of the slides I was talking about the dynamics parameter on the hemoglobin response model? That parameter is related to red blood cell turnover or red blood cell lifespan. Typically, the red blood cell lifetime value in dialysis patients is between 60 to 120 days. So the effect of the drug that we are dosing every 30 days will persist over 60 to 120 days. Why then is this part important? We want to be able, instead of just looking ahead 30 days at our next dosing insert, we want to be able to predict the extended effect of our current ESA dose adjustment over the next 3 to 4 months. And this way we will achieve better stability in the hemoglobin response and possibly eliminate the excessive variability that we are targeting. So the next step, this is the exciting part actually, where we realize the potential of using AI methods. The next step, the next challenge that we wanted to target is looking at our patient data and electronic health records, looking at them over time, and decide what are the individual patient's dose response profile. Why is that important? We wanted to make sure that each model predictive controller that we use to guide our ESA dose adjustments, our individualized treatment, was fine-tuned to individual patient needs. So we're looking at true treatment individualization at this point. So the first step in attacking the challenge was looking at our hemoglobin and ESA data in our EHR, our treatment data. So we made this scatter plot that shows hemoglobin concentration as a function of ESA dose. If you look at this plot, it appears a little bit counterintuitive. There is a clear negative correlation between ESA dose and hemoglobin concentration. And in fact, when I showed this plot to our nephrologist, the first reaction was, Adam, you're doing something wrong. Because you would expect that as you increase the ESA dose, the hemoglobin concentration will go up. This shows the opposite. Why is that? We quickly realized this is the effect of collecting the data generated in the feedback loop in the treatment. So what this data shows us, it doesn't really show that the ESA dose increases hemoglobin. It shows us that some patients need very little ESA to achieve high hemoglobin levels, extreme hyperresponders in green, whilst other patients at the opposite end of spectrum need a lot of ESA dose and they still have trouble achieving the hemoglobin target. So what you see here, what we did is looking at the scatter plot that appears counterintuitive. We applied unsupervised learning, we applied data clustering to identify these 5 distinct groups of the individual patient dose response profiles. And if you look at the individual regression curves, now you see the individual dose response characteristics. So next step, we take individual dose response profiles and we create a multiple model predictive control to target individual patient needs. Here's an example of a multiple model predictive controller with 3 specific controllers targeting the needs of hyper, medium, and hyper responder. So each of these controllers, shown before, they are fine-tuned to perform optimally for patients with these response characteristics. So for example, the model predictive controller for hyper responders is generally going to recommend very tiny dose adjustment because the patients are that type of patient is very sensitive. Whereas on the opposite end of spectrum, the model predictive controller for the hyper responder will tend to generate more aggressive dose adjustment because that patient is more on the flatter part of the dose response. Now, individual patients can partially match the dose response profile. That's what this dose response profile matching blood test here. And this particular patient shown in this example, we see that it's this patient might be a hyper responder to a degree 0.6 and a medium responder to a degree 0.4, meaning the overall dose recommendation for this particular patient will be calculated by weighted averaging the two individual recommendations from these green and blue block. So that is the principal operation behind clinical decision support system called Smart Anemia Manager that we devised at that point. We implemented it in our dialysis facility and tested it through a randomized controlled trial in 60 patients, where we compared it to a standard of treatment, which was a physician-derived anemia management protocol, shown here at the control group. Treatment group were patients guided whose anemia treatment was guided by Smart Anemia Manager. We had a supervising nephrologist approve all of the doses in both study groups. And this plot right here shows the outcomes of the study, the most important outcome of the study, namely hemoglobin concentration over time, represented as quarterly box and whisker distributions, comparing hemoglobin variability between the control group, the anemia management, the protocol-driven management, and the Smart Anemia Manager guided management. We see from this plot, number one, that the white group, the treatment group, has achieved much tighter hemoglobin distribution near the target range compared to the control group. One more important thing, as you look at box plots for Q2 and Q4, they appear to widen compared to Q1 and Q3. That's a sign of long-term variability that we have been talking about before. Also, please note that interquartile range for Q3 and Q4 exceeds the lower bound of the target range, 10 to 12. That was a standard target range for anemia management at the time. Why is that important? We looked at transfusion. We looked at blood transfusions between the two groups over time. And as you see in the control group, where there was a larger percentage of hemoglobin values below 10, there was an increased risk of transfusion. Goes back to our original statement. So we have shown in the study that not only we are able to control the hemoglobin distribution better, but we are also decreasing the risk of transfusion in those patients, which is the goal of anemia treatment. In 2013, we implemented this system facility-wide in all patients. And here is an example of an individual patient who was controlled by a standard anemia management protocol between year 2009 and 2010. You see that this patient shows a large variability in hemoglobin associated or correlated with large changes in ESA dose. After we switch this patient to the new approach, the hemoglobin levels stabilized, and so did the dosing pattern. Please note the difference in the total ESA dose used. This is almost a triple decrease in the total ESA dose that was delivered to this patient. So this is the timeline of this work. We started in 2002 through 2013, where we implemented this system in our dialysis facility. In 2017, we were approached by company Doses, who licensed out this intellectual property. We received a patent protection for it. In 2019, we received FDA clearance. In 2020, the market penetration was 30%, that which is about 150,000 patients in the United States. We found through internal data analysis that after the introduction of the system, the patient exposure to ESA decreased by 30%, which is not only beneficial to the patient, according to FDA recommendations, but it also improves cost effectiveness of the treatment. One little detail about dialysis patients, most of them have Medicare as the primary insurance, meaning if this approach is saving American taxpayer money that goes to pay for this drug. That's a little shameless plug. This is the user interface that Doses has created for this product. You'll see, you can follow hemoglobin trends and the ESA dosing trends over time. We have also added the ability to individualize iron dosing. And we also alert physicians to abnormal hemoglobin values, so they don't have to completely rely on the system when the patient needs extra care. Again, this system, just like every engineering system, it works well on the data it has seen. Patients are, real life patients are much more heterogeneous than that. There's always gonna have to be a human in the loop. So we just, what this really does, it really makes it easier on you, saves you time and money in performing this task. So speaking of the 30% ESA dose decrease that we observed, United States Renal Data System recently published analysis of nationwide dialysis facilities, including anemia outcomes. On this plot in blue, you see the total average monthly dose of erythropoietin alpha, which is the primary ESA that Smart Anemia Manager is aimed for. And in green, you see hemoglobin distribution. Now, mean hemoglobin values. On this plot, you will notice that between 2020 and 2021, there was about 14% decrease in ESA utilization. This incident, this decrease in ESA dose utilization between 2021 coincides with the introduction of SAM to 30% of the dialysis market in the United States. So I'll let you draw your own conclusion. I'm not implying anything. Okay. Let's switch to present. This is going to be much more involved, much more complex, and much more interesting. Mineral bone disorder. It's next to anemia. It's one of those most important complications of chronic kidney disease. It involves skeletal and cardiovascular system. So patients with mineral bone disorder are at increased risk for bone fractures and vascular calcification. This disorder begins in early stages of chronic kidney disease and is one of the most serious complications. What are the challenges? Well, the number one challenge is that the current therapeutic targets are the proxy biochemical markers of end organ damage. So we're not looking directly at the skeletal or cardiovascular markers. We're looking at markers of the mineral metabolism, calcium and phosphate. And why are we doing that? Because there is not really an easy way to predict, to model, to analyze, to predict and prevent the end organ damage. Last but not least, the treatment guidelines are the evidence and the treatment guidelines for mineral bone disorder released by Kidney Disease Improving Global Outcomes, in short, KDIGO. These guidelines, due to the lack of evidence, they're largely opinion-based. This is a block diagram of mineral metabolism. It's a very complex process involving multiple feedback loops. The most important, the two key players for us are calcium and phosphate in blue. We have them traveling to different parts of the different organs of the body. The most important ones for us are the bone compartment and the vascular compartment. So what happens in in patients with kidney failure, since the kidney is involved in the process, kidney failure dysregulates this whole homeostasis, eventually leading to minerals escaping the bone, increasing the risk of bone fractures, and the minerals deposition in the vascular smooth muscle cell tissue, increasing the risk of cardiovascular events. Nephrologists have a whole armament of interventions to try and slow down or treat this process. And those are phosphate binders. Those are oral pills that patients take every day. Dialysis, active vitamin D, also trial, and calcium mimetics. What's the challenge here that we can use artificial intelligence for? This is a combination treatment. So how about we use artificial intelligence, machine learning, mathematical modeling to figure out what is the optimal treatment, optimal combination of these drugs to achieve our goal in decreasing the risk of bone fractures and cardiovascular events. This is just a quick diagram of quantitative systems pharmacology model. QSP stands for quantitative system pharmacology. This represents in a mathematical way the same thing that we saw on the previous slide. This is a multi-compartmental model that allows us to describe with nonlinear differential equation mineral movement between different compartments of the body. What's so special about this model? Well, what advantage does it give us? If you look at the mass balance equations for the central compartment for the extracellular fluid, you will see that with this model, we are able to estimate the mineral movement into the vascular smooth muscle cell tissue, the vascular calcification, and we're also able to estimate the movement of mineral out of the bone compartment. So what can we do with this model? We can use it to directly estimate the risk that we are really interested in. Okay, the risk of the risk of bone fractures and the risk of cardiovascular events. What more, since we have included in the model a different intervention, we can now investigate how these different interventions affect these abnormal mineral movements over time. And this plot shows how these different interventions applied in a stepwise fashion decrease the abnormal calcium flux from the bone to extracellular fluid in blue, and from the extracellular fluid into the vascular soft tissue. So what now? Remember when I mentioned reinforcement learning as a way to sequentially to design sequential decision process for treatment planning? Well, let's do it right now. So this block diagram represents a reinforcement learning setup that is based on the model shown before. The model generates observations of calcium, phosphorus, and PTH, which are the standard markers that clinicians use to monitor the disease progression for mineral bone disorder. And then these observations are fed into what's called the reinforcement learning agent, represented here as a deep neural network. This deep neural network then generates treatment decisions, which are the dose adjustments for phosphate binder, vitamin D, and a calcium mimetic. Making these adjustments, we observe the model response in terms of change in the bone calcium efflux and the vascular calcium influx. This information generated by the model is used to create a learning signal in reinforcement learning world called reward. And that learning signal is used to adjust our reinforcement learning agent such that over time it learns to minimize CA sub B and CA sub V, which are representing our abnormal mineral movement. Okay. Once trained, we can validate it by removing the learning feedback signal. We can validate it in normal fashion just by letting it observe calcium, phosphorus, and PTH and perform the dose adjustments accordingly. So this setup, we simulated in silico using our model and compared it to 3 other strategies. And those were, in blue, the KDIGO strategy, which was a physician-based protocol implemented as a computer script. RL KDIGO, which was a reinforcement learning agent trained to optimize mineral bone disorder according to KDIGO guidelines, which focus on normalizing calcium, phosphorus, and PTH. Okay, so anything with the word KDIGO in it, the top 2, they're not looking at abnormal mineral movement. They just focus on optimization of calcium, phosphorus, and PTH. Flux is a reinforcement learning agent that was trained to minimize abnormal mineral flux, hence flux. And last but not least, we decided to combine optimization of KDIGO guidelines and abnormal mineral movement. After simulating this treatment in a large cohort of virtual patients, we then looked at the relative reduction in abnormal mineral movement, specifically looking at bone calcium efflux reduction shown here. And on the next slide, I'll show you what happens with the vascular calcium influx as well. Because the phosphate binder is an oral agent taken by patients at home, we wanted to investigate how robust these approaches are, different levels of patient adherence to their phosphate binder prescription. So we simulated full 100% adherence down to 25% adherence. And what stands out at this plot, quite as expected, is that if we focus on minimizing the abnormal mineral movement, the teal cloth, this approach not only achieves the best reduction in bone mineral efflux, but it is also very robust to substandard patient adherence to their phosphate binder prescription. This is the effect of phosphate binder adherence on the change in vascular calcium influx reduction. Again, if we target the abnormal mineral movement directly, we get the best reduction. In vascular calcium influx. However, as opposed to the previous slide where we had a good robustness to diminishing phosphate binder adherence, we see that the vascular calcium influx is much more sensitive to patient adherence to their binder prescription. So this work right now is very much in progress. We are trying to improve, number one, we are trying to improve the model. We are working on new reinforcement learning algorithms. We're hoping eventually to take this to clinical application as well. So what I hope to have shown you through this presentation was the advantages of using artificial intelligence methods as well as machine learning methods in disease management based on our experience at the Division of Nephrology. Our findings, we found that using these methods improves our understanding of disease mechanisms. We are able to better utilize patient treatment data to individualize the treatment. We now have better methods to plan treatments of an extended period of time, just as shown in the anemia management case. And last but not least, the work that we're doing on mineral bone disorder, we hope to find treatment strategies targeting the end organ damage better than the current standard of care. I would like to acknowledge all of my collaborators on this work, with special thanks to Don Castor and Viva Nayak for helping me prepare this presentation. Funding for this work came from National Institute of Health. My anemia research was fully funded through K25 and R1. The Department of Veterans Affairs was involved in the anemia management research through Mike Breyer. And Department of Veterans Affairs is also involved in mineral bone disorder research through Dr. Lederer and Mike. There was funding from Kentucky Science and Engineering Foundation to help us bring Smart Anemia Manager to market. And with that, I would like to finish my talk.
Thanks, Dr. Gaweda. Of course, I have a big question for you. All of this has sort of been on end-stage renal disease, CKD stage 5. And my big concern is we have so many patients where we'd like to stop them from actually getting there. And we do have data on the kinds of things that I would think an artificial intelligence program could help us. The linear relationship between blood pressure and animal protein intake and diabetes. If we could model those three things and tell people exactly what their goals are, of course, animal protein should be 0, but it may be difficult, even with the plant-based diet, only 37% diabetics have it resolved in 6 months, according to the British Medical Journal article a few months ago. So that leaves a lot of people still. So then the blood pressure, we struggle with all the vascular complications of that calcium phosphorus products you're talking about. So how can we actually target what the blood pressure really should be? Should it be, we set our target with the hypertension guidelines in 2017 at 130, but I'm always feeling like 120 is considered elevated, and there's a doubling for every 15 millimeters of mercury. There's a doubling of mortality above 115. Therefore, shouldn't we come up with an AI program that models those three things and stops our CKD 3A, B, and 4 from getting to stage 5? Can you do that for us?
This is Mike Breyer. It sounds like you're offering Adam a blank check to approach this problem.
I'll do it cheaper. I'll do it cheaper.
So here's the deal. All of these are interrelated, and so Adam's he's worked on a base model.
I wanted to keep it secret.
And each one of these things gets added. Like FGF 23 is important for mineral bone disorder and anemia. So as the model gets bigger and bigger, I think we'll be able to answer those questions. And as in point of fact, with the work we're doing with CKD MBD, we've identified that the targets for calcium and PTH probably are too low.
So I have a quick and to the point answer to Dr. Williams, which is we are actually already doing this. I just wanted to keep it secret for now.
Fantastic to hear.
You and I already had a small email exchange about it that I'll follow up on. But this is a project.
That would be spectacular.
We will brag about it when we have results that we can brag about.
Fantastic. And more patents for UofL and you. That's good. I'm sorry, so I preempted a little bit, Dr. Youssef, or you're running the question and answer, but I didn't think you could see my hand raised. I guess we're driving back from Normandy.
Good lead-off question. There's a question in the room.
So on the anemia side, you had a physiologic outcome that you could actually measure for an important variable, hemoglobin, for instance. But like for vascular calcifications or bone mineral density or whatever, are you including those types of physiologic variables in your data?
Work in progress. Yes, we are. Yes, we are.
Adam, repeat the question.
So Dr. Jacobs is asking about more directly measuring vascular complications in the MBD model.
And bone.
And bone complications. And we all know the answer.
I think there's some online, Jason.
There's one question. It's from Dr. Krishnasamy.
Mhm.
It says, "Great work, thank you." Says, would this be something to look into with steroid replacement in adrenal insufficiency, such as Addison's, where we don't have clear biomarkers to adjust doses?
Yes, if we have data that we can use, data and physiologic concept, as I have demonstrated, that we can base our work on.
Now,
So yes, that is an interesting application. If there is a need, there is a solution.
What we do is we rely on people like Don Castor who are in the lab, work with animals and cell culture tissues that will identify the pathways of disease that can be incorporated into the mathematical model. And then when we treat the model, we can see how those parameters change until such a time as assays are developed to measure these things.
There's a question.
Hi, I'm Erin Murphy. I work in primary care. What I loved about, especially the anemia study, is kind of this response to, okay, there's something that we see sort of variable practice or maybe even standard practices, but the phenotypic kind of like response to that treatment is different. So let's look into that. I'm curious, like something that's really hard as a primary care doctor and as a nephrologist is blood pressure management and which antihypertensive do you choose? There seems to be this wide variability in how patients respond to individual agents. I'm curious if it's something you're looking into because we don't have markers for how is a patient going to respond to, you know, this medicine versus that medicine. And it just seems like an area of practice that we could really, you know, more rapidly improve blood pressure, avoid hypertensive emergency, that kind of thing.
This is an area that we've been wanting to attack for a long time. Just need some collaborators if you're interested. Wow, because this is absolutely great idea.
Oh, we get from the chat.
All right, Adam, thank you very
Thank
much.
you.
Great talk.
Congrats.